There was diplopia when left gaze, and the right maxillary trigeminal nerve examination was decreased. We assessed the patient with binocular diplopia due to filler infiltration at subconjunctival bleeding of right eye and also ectropion of right eye. We gave methylprednisolone 2 times 12 milligram orally and also vitamin A palmitate 10 milligram eye ointment 2 times and also continue other treatment like vitamin B, sodium hyaluronate, esomeprazole, and also the patient can control to Palembang Hospital. On the last day follow-up, there was no double vision, and the eye movement were restricted adduction -1 of right eye and good to all direction of left eye. Her visual acuity of both eyes was 6/6, and there was light ectropion in the nasal region of right eye. There was also subconjunctival bleeding of right eye, and the other anterior and posterior segment of both eyes was within normal limit. And we still diagnose the patient with binocular diplopia due to filler infiltration and some conjunctival bleeding at ectropion of right eye. We gave the patient methylprednisolone 2 times 8 milligram, and then tapering off into 2 times 4 milligram, then tapering off become 1 times 4 milligram orally, and continue other treatment, and the patient control in 3 weeks. Dermal filler injection is an aesthetic procedure that have recently gained considerable popularity. According to the International Society of Aesthetic Plastic Surgery 2022 statistic, dermal fillers are the second most popular non-surgical procedure after botulinum toxin injection, and the number of filler injections keeps on increasing since 2017 to 2021, with a 73.3% increase in calcium hydroxyapatite injection and 60.1% increase in hyaluronic injection. Dermal filler injection is a replacement aesthetic procedure where filler is used for volume filling and soft tissue augmentation. Commonly used filler agents include hyaluronic acid, collagen, autologous fat injection, and other synthetic materials such as polylactic acid and calcium hydroxyapatite. And hyaluronic acid is the most commonly used filler agent. Dermal filler injection have non-ischemic and ischemic complications. Ischemic complications of filler injection include vision loss and ophthalmoplegia or double vision, soft tissue necrosis, cerebral infarction. And non-ischemic complications include bruising, erythema, edema, angioedema, nerve injury, skin discoloration, nodules inflammatory and non-inflammatory. A systematic review by Orange et al. Found 46 articles of complication of dermal filler injections, including 164 patients between January 2003 and February 2020, and skin necrosis, vision loss, blepharoptosis, and ophthalmoplegia are some of the most frequently reported severe or permanent complications of filler injection. As of January 2022, 211 cases of vision loss as a complication to dermal filler injection has been reported. This number is most likely an underestimation, and the actual number of cases like many falls higher. The presentation of a patient with vascular occlusion of the ophthalmic artery involves blindness and also periocular symptoms, usually very soon after filler injection, and can present with concurrent ptosis and also ophthalmoplegia. Several mechanisms have been proposed for the pathogenesis of optic neuropathy following filler injections. First, vascular occlusion, being the most mechanism, involves obstruction in ophthalmic artery in its branches, leading to ischemia and damage to the optic nerve. Second, fillers may exert mechanical pressure on the optic nerve and its surrounding tissue, causing compression on the nerve. Third, fillers may also trigger inflammatory response in periocular tissue, leading to edema and subsequent optic nerve damage. And fourth, improper injection techniques such as intravascular injection or unintentional injection into critical structures may directly damage optic nerve or its blood supply. The etiology of this vision loss is usually due to retrograde arterial embolism into branches of the ophthalmic artery, including the retinal branches. The glabella, temple, and nasolabial folds have vasculature that commonly anastomoses to the ophthalmic artery. Thus, the most common location that cause vision changes are the nasal regions, followed by the glabella, forehead, and nasolabial folds. The most common occluded vessel are the ophthalmic artery, central retinal artery, branch retinal artery, and nasociliary artery. Occlusion of the ophthalmic artery is usually secondary to injection in the nose, while occlusion of the retinal artery is secondary to glabellar injection. Given the various anastomosis in the different facial arteries, there are several injection locations that can cause ocular complication. This vascular occlusion may present as central retinal artery occlusion, branch retinal artery occlusion, choroidal artery occlusion, anterior ischemic optic neuropathy, and also posterior ischemic optic neuropathy. Filler injection has also been previously seen to cause diplopia and ophthalmoplegia. A study found that 71% of patients with artery occlusion after filler injection also developed ophthalmoplegia. Proposed mechanism of ophthalmoplegia after dermal filler injection includes cranial nerve ischemia secondary to vascular occlusion from retrograde emboli leading to ocular muscle nerve palsy and direct ocular muscle ischemia and inflammatory responses. A case of restrictive ophthalmoplegia has been previously reported. CT orbit in the case showed enlargement of right medial and inferior rectus muscle, and radiological findings in the case were more in keeping with restrictive ophthalmoplegia rather than neurological cause. The proposed mechanism of the ophthalmoplegia in this case is that direct infiltration of the filler materials into the surrounding tissues and muscle the volume expansion properties of hyaluronic acid itself cause the inflammation and tissue edema of the affected muscles. Furthermore, the enlargement of the extraocular muscles involved mainly the right medial and inferior rectus, probably due to the close proximity to the injection site and also due to the gravitational force, which cause a denser filler substance to be distributed in downward direction. The site of edema in this case report is similar to our case. Chung et al. In 2023 reported a case of acute diplopia without vision loss immediately after hyaluronic acid-based filler injection. Alignment exam was notable for two publication of exotropia that worse in left gaze as well as 2 PD of right hypertropia worse in inferior gaze. Patient was given immediate management of prompt injection of 300 units and a subsequent 150 units of hyaluronidase into the affected area. Systemic therapy that include nitroglycerin paste, aspirin, and empiric dose of amoxicillin quinolone, patient's diplopia completely resolved after 2 months. And diplopia presented with skin mottling, discoloration, and numbness, skin necrosis, and worsen on follow-up and left hypertrophic scar. Downey et al. In 2022 reported the only two cases reported of isolated ophthalmoplegia without evidence of other skin or ocular injuries. In the first case, a 54-year-old female presented with acute onset headache, vomiting, and diplopia during molar and temporal injection of hyaluronic acid. In the second case, a 37-year-old female presented with binocular diplopia that developed following injection of unknown filler to the upper face. Neither of the two patients had a skin necrosis or ocular abnormalities other than motility deficit. An inflammatory response mechanism was considered more probable than an ischemic etiology. One patient improved after methylprednisolone and aspirin, 81 mg, and the other did not improve as she presented 3 until 4 months after the complication. A case report by Diaz et al. In 2024 shows another rare case of isolated ophthalmoplegia. Patient presented with diplopia and nausea and exhibit right hypertropia and suggesting a right inferior rectus paresis due to vascular injury of the infraorbital artery. Patient was managed with immediate injection of hyaluronidase followed by another dose of hyaluronidase on follow-up and also oral steroid dexamethasone 8 mg orally for 5 days. 3 weeks after filler injection, patient was found with only a small deviation in down gaze but no complaint of diplopia. Like filler-induced vision loss, no high-level studies exist for a clear recommendation of the management of diplopia after dermal filler injection. Previously reported management includes injection of hyaluronidase if hyaluronic acid filler is used, steroids and vasodilator, antiplatelet, and or anticoagulant when vascular occlusion is suspected. Unlike the most irreversible nature of vision loss after iatrogenic ophthalmic artery occlusion, filler-induced diplopia may have better prognosis. Ophthalmoplegia related to filler injection may recover spontaneously in 77% of patients. However, as most patients with concomitant ophthalmic artery and retinal branch occlusion are blind with no right perception, sensory strabismus secondary to unilateral blindness may eventually develop in nearly half of patients during follow-up and requires strabismus surgery. The new injury severity scale were proposed by a paper by Sancheng C. et al. In 2022. According to the new scale, a higher grade indicates a worse prognosis. With this scale, we can inform patients about the possible prognosis even at the initial visit. The new scale is based on the anatomy of the central retinal artery, ophthalmic artery, internal carotid artery, and their branch. The most dangerous injection site resulting in most severe ocular complication, grade 3 and grade 4 was the glabella. The blood supply of the forehead, glabella, and nasal region is also from distal branches of the ophthalmic artery, including the supraorbital artery, supratrochlear artery, and dorsal nasal artery. Autologous fat injection tends to result in a much more prognosis than a hyaluronic acid injection. We hypothesize that this may be due to the larger size of autologous fat particles than hyaluronic acid molecules. The size of autologous fat particles varies widely, ranging from 0.02 millimeter to 1.4 millimeter, while the molecular size of hyaluronic acid varies in a small range from 0.35 millimeter to 0.9 millimeter. Therefore, autologous fat particles can obstruct the main trunk and all branches of the ophthalmic artery, approximately 1.3 millimeter in diameter of the trunk, leading to much worse and more diverse prognosis. In contrast, hyaluronic acid molecules usually obstruct the distal branches of the ophthalmic artery. A systematic review by Kapoor et al. Of 44 case reports of hyaluronic acid filler-related vision loss from 2004 to June 2019 showed the different sites of hyaluronic acid filler injection that resulted in vision loss. The nasal region is the most common injection site in hyaluronic acid filler-induced vision loss case. All sagittal area were in the danger zone, having ICA and ECA anastomosis and in the face involving upper and mid-face regions. Ophthalmic artery occlusion was the most common pattern, with the total 12/31, around 38.7%, followed by central retinal artery occlusion, with total 8/31, around 25.8%, and branch retinal artery occlusion, with total 6/31, and around 19.4%. And also posterior ischemic optic neuropathy alone was reported in 2 cases. In another case, it was seen in combination with branch retinal artery occlusion, and anterior ischemic optic neuropathy and posterior artery occlusion were seen in one case each. Out of these 45 eyes, in 44 cases, 9 involved eyes, around 20%, had a full vision at the time of follow-up, while in 13 eyes, around 29% had partial vision ranging from light perception to 20/25, and in 22 eyes, around 49%, there was complete vision loss. And partial vision loss at presentation was found to be associated with better prognosis. 17 cases showed a definite improvement in vision at follow-up compared to the visual status at the time of initial presentation. Out of these 17 cases, 10 showed complete recovery, while 7 cases showed partial but definitive recovery. In these 17 cases, 15 had partial vision loss at the time of presentation, while 1 had subjective total vision loss without any substantiated diagnostic support. One patient had no light perception at the presentation, which improved to hand movement at the follow-up. "22 out of 44 cases in the systematic review had periocular changes of either ptosis, ophthalmoplegia, and exotropia, and their combinations. Ptosis was the most common periocular change. Ptosis was found in 21 over 22 cases, followed by ophthalmoplegia in 17 cases. 6 cases was found to have all ptosis, ophthalmoplegia, and exotropia.
Sorry, Dr. Lily. Can you sum up to the conclusion? Sorry.
Oh, okay. Okay, Doctor.
Any question? Sorry. Thank you.
Okay, so the take-home message is, despite the increasing popularity, filler injection can result in devastating ocular complications, including vision loss and diplopia. The primary mechanism behind vision loss and diplopia from filler injection is vascular occlusion caused by emboli, and awareness of the ocular complication associated with filler injection and studies on their management are needed. That's the end of my presentation. Thank you for your kind attention. Good evening. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Lily, for the interesting case presentation. You showed a devastating complication of filler injection. Then we will move on to the discussion. Are there any questions from the audience or comments from the panelists? Maybe I see the question from Prof. Chi. Thank you, Prof. Chi. Prof. Chi asked, can it occur many years later? I have a patient who developed a CRAO years after having a dermal filler procedure. Maybe Dr. Lily, you want to try to answer the question or from the panelists, please?
Sorry, ma'am, the voice is not so clearly.
So Prof. Chi has a question. Can it occur many years later? Because Prof. Chi have a patient who developed a CRAO years after having a dermal filler procedure. So maybe do you have an answer for this question?
Thank you for the question. Regarding to theory that I have read, some cases can develop into CRAO, but in our cases, maybe because it's acute, it's happened only 1 month, and the retina is still within normal limit, and there is no abnormal finding in retina, so we don't see any CRAO or another abnormalities in our case. But from what I have read, it can develop into CRAO.
Thank you, Dr. Lily. Maybe Dr. Salma or Dr. Cynthia, do you have any comments on this?
Okay, thank you, Dr. Sita. Yeah, sorry, I didn't hear the answer from Dr. Lily, but as a usually the the CRIAO, after filler injection is in an acute phase within hours or days. In symptomatic review, we can see the late onset is between 6 until 7 days. And as we know, this is the non-permanent filler, and it's biodegradable and also and it lasts long, about 6 until 18 months, I guess. So it is non-permanent filler, and the CRO from the systematic reviews occurred in acute phase within hours, and the late onset is about 7 days. Yeah.
Thank you very much.
Thank you.
Yeah, Mr. Sharma. Maybe Prof. Clement, do you have any comments on this case?
Yeah, so I don't know, Lily, if you can show the MRI scans again of the muscles that are involved. I would agree with what Salma has said just now, that it would be unusual for a dermal filler to remain years after and then flow into the blood vessels. It does sound a little bit long if the CRAO occurs much later. I don't know if there are any oculoplastic people attending this evening's meeting. It would be lovely to hear from them because they have a little more experience with the fillers. Neuro-ophthalmologists just pick up what happens after, but not really involved in the first part. You mentioned the mechanism, right? The mechanism for fillers to cause a diplopia is think direct infiltration or a leak of the filler to the muscle. And it's interesting that you showed a little, but this is in T2. I don't know if you have any. These are T2 images. I don't know if you have a T1 contrast image that shows the enhancement of the medial rectus and inferior rectus. Although you can see on T2 that at least on T2 there is a little bit of T2 hyperintensity in the muscles, suggesting that that's where it may have gone. The question I had on this, and I was trying very hard to follow along with the slides, was whether there was any pupillary involvement, because many of the examinations showed that the patient was examined after the pupils had been pharmacologically dilated. So was there any anisocoria at any time?
Mr. Lily?
Lily,
Is there any anisocoria?
During any of the follow-up, was there any anisocoria?
No, Prof. There is no anisocoria.
Okay, I mean the reason I'm asking is because it really looks kind of like a partial third nerve palsy with a bit of ptosis, and with medial rectus and inferior rectus involvement with limited adduction and down gaze. Makes you wonder whether there was a third nerve palsy, because it does seem like it mimicked a third nerve palsy with a ptosis and all those other signs. So if there had been an anisocoria at any time, I would have wondered whether there was a third nerve palsy instead, right? And if it was ischemic, then it would also have resolved. If it was an ischemic third nerve palsy, then it might also have resolved after the what do you call it, revascularization. So that's one of the possibilities. I see there are actually some rather interesting questions there, like whether we can protect the eye when you've done a filler injection, and there's one about whether the diplopia. Okay, maybe it would be nice to know whether the diplopia occurred immediately after the injection, or how delayed was it. The diplopia. Although I dare say, if you show the pictures of the patient, you have a time sequence of pictures right at the beginning. It almost looks like she has an exotropia very soon after the injection. If you go back a couple of slides.
On the first slide, I think.
Yeah, the first slide, the one with the pictures of the pictures of the patient's face. So yeah, okay. so the 4 days after the 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 filler, right? She's got an exotropia already, exotropia and a hypertropia on the right eye, and then very quickly after that, she's got so 4 days before admission. So how many days after the filler was this?
4 days, Prof.
4 days, right? So 4 days after filler, she's already exotropic, and a day after that, she's got a bit of ptosis as well. So that's the part that made me wonder when you see the ptosis and the partial ptosis there, that whether or not this was a third nerve palsy, and then with the necrosis at the tip of the nose, I'm beginning to wonder whether the more what do you call that? More blood vessels are involved down there. Whether it's beginning to be a bit like a cavernous sinus thrombosis at the same time, right? Were there any? There was an MRI scan done 3 days before admission. Did that show anything?
The MRI was done 3 days before admission in Abdul Wali Hospital, Prof.
Was there any information from that MRI? Oh, this is the one that you showed just now, is it?
Yes, Prof. Yeah. I have saw this one, Prof.
Okay, this one. All right. Okay. Right. Okay, I see. Okay.
Prof.
Okay,
Clement, actually the patient is right away diplopia after the injections.
straight
This
away,
one
right?
is 4 days before admission, 4 days before patients meet Dr. Salma. But the picture is right away after
Okay.
the injection. So the patient have her on pictures.
Right. So do we know whether the injections were given near the orbit that that the filler would have gone all the way to the medial rectus, and then at the lower lid I can imagine it going to the inferior rectus because it's very close to the lower lid, but the medial rectus seems a little bit far. So I'm just wondering where the injection was given around that area, whether we have any information on that.
Yeah, actually, we don't know the how many injection that given Prof. Clement, but it's around the glabella, forehead, nasal, and also temporal region, like zygomatic and jawline. Yes.
Okay.
It's very high risk for vascular emboli in this case.
Thanks. I should stop asking and then let you answer the rest of the questions about the most recent one about the recommended route of administration of hyaluronidase, and then also the one about protecting the eye. All yours, Salma.
Actually, from the this is the dermatology or competency actually, but the doctor usually talk about the risk of this complication for all the patient from the beginning. So the patient already know about this, all the risks that could happen about the vision loss, ophthalmoplegia, and the doctors also can check for the visual loss after the injection, and did the hyaluronidase injection if they found vision loss immediately after the injection. This is the first rescue treatment for this case. Like in this patient, she got 2 days before admission, she got hyaluronidase injection the first 2 days before admission, and also just before she came to our hospital. So and since the vascular anatomy in the around the nasal labial and zygomatic is very complex actually, Prof, and also is very varied about among people. We cannot predict the complication could happen or not in this patient. Maybe that can answer the question.
Okay. Thank you, Dr. Salma and Prof. Clement. Maybe the last question from Dr. Priscilla. She asked about the recommended route of the administration of the injection of hyaluronidase for filler-induced ocular complication. Is it subcutaneous, intraocular, maybe not intraocular, or retrobulbar injection? And this is my question. Uh, in this case, the possible mechanism was the infiltration of the filler into the extraocular muscle and then causing inflammation. In this case, what is the role of the IV steroid administration? Do you have any comments on this, Dr. Salma or Prof. Clement or Dr. Syntia or Dr. Sidik? Please, thank you.
Okay. Yeah. There are several recommendations actually, doctor, for the question hyaluronidase injection. First, it can be injected in the injection area for the like ophthalmoplegic cases, but in vision loss cases like CRAO or DRAO and optic nerve under optic neuropathy, it can be injected retrobulbar, and the dose is varied among cases, since there are no guidelines actually about this procedure.
Thank you, Dr. Salma. Because of the time, we have to move on to the next cases. Thank you very much. And now we have Dr. Jaslyn Oh from NUH. She will present two cases entitled Beyond Double Vision, Exploring Unexpected Origins. Then please note that your presentation will last for 20 minutes maybe, and then there will be a 10-minute discussion. Please, Dr. Jaslyn.
Great. Good evening, everyone. Thank you, Dr. Lily, for your presentation. Could I share my screen? Great, thanks. Oops. Can you see my screen? Okay, all right. So today we'll be presenting on two cases. Maybe we will take a short break after a short discussion break after the first case. Okay, so the first case is a 33-year-old gentleman who's an occasional smoker with no further past medical history. Ocular history-wise, he has a left eye anisometropic amblyopia because he's a lot more myopic in that eye. He presented with binocular oblique diplopia for 2 days, which was of sudden onset and worse on left gaze, and had a bit of nausea when he has the diplopia, but it resolves after he covers each eye. Now, associated with that, he had a left-sided throbbing headache with left retroorbital discomfort, but he says that it's probably his kids keeping him up at night, and his wife was undergoing chemotherapy, so he thought that was the stress from childcare. Now, on examination, the optic nerve functions were intact. There's no RAPD, and the anterior and posterior segment examinations were pretty normal. And this is on ocular motility. It's a little bit subtle on the 9-gaze photos, but if you can tell, the left eye has an abduction deficit over here. Now, orthoptics show that there's left esotropia that is worse on left gaze and no esotropia at all on right gaze. And there were hypometric saccades of the left eye towards the left. Corneal sensation was intact and the contiguous cranial nerves were normal and power was full in all 4 limbs. So right now, the impression was a left cranial nerve 6 palsy in an otherwise well gentleman with only a history of occasional smoking. He was managed with symptomatic relief by occlusion of the left eye, and he was teed up for an MRI brain with contrast, sent off an ischemic risk factor screen, and he was referred to ENT to rule out a nasopharyngeal tumor with a nasal endoscopy. Now, this is the MRI, and looking at the arrow sign, there is actually a bulky enhancement of the left anterior cavernous sinus, superior orbital fissure, and extending into the orbital apex. And there was also adjacent bony involvement with a bit of dural thickening also. He had this small polypoidal, the yellow one, the yellow arrow, small polypoidal sphenoid sinus tissue here. But otherwise, the main issue was the one labeled in blue, where there was mass effect around the orbital apex and even a distension of the left optic nerve sheath. So the patient was recalled immediately and he was admitted for further investigation. So now we repeated his orthoptics, and we can tell that he no longer just has a left esotropia, but he also has a left hypertropia, which was worse on left gaze and right tilt, and actually that isolates to the left inferior rectus. Yeah, but the intorsion was intact. Otherwise, he had no anisocoria, no ptosis, and continues to have no RAPD. But we did his visual fields, and these were his first fields, but there's a bit of a denser left inferior nasal defect over the on the left eye, a bit of a paracentral defect on the right eye. So right now, our working diagnosis was that this patient, young gentleman with a left anterior cavernous sinus, superior orbital fissure, and orbital apex lesion, which is causing a left cranial nerve 6 palsy, possible inferior division of the cranial nerve 3 because of the left inferior rectus weakness, and possible left optic neuropathy. So differentials for the etiology would include inflammatory, infective, neoplastic, thrombosis even. And so he was referred urgently to the ENT and neurosurgery team to consider the cavernous biopsy of the cavernous sinus lesion. He was also referred to neurology for lumbar puncture. And so he managed to go for the biopsy quite quickly. And this was what they found intraoperatively. There was this reddish gray tumor that was kind of invading through the posterior wall of the right sphenoid sinus. Yeah, so strangely, it was from the other side. Yeah. So other investigations, we did his myasthenia workup and thyroid panel was all normal. The other autoimmune screen were all normal. Pre-steroid workup was normal. Lumbar puncture, besides a bloody tap, was also normal. And there was no bacteria or fungus that was isolated. And also no lymphoproliferative disease in the CSF. So he started on oral dexamethasone for MGBT after the biopsy. And actually 2 days later, his visual fields improved. And he was continued on this. And 2 weeks later, his ocular motility was full. And subsequently, we tapered him off the dexamethasone. So now the histopathology returned. And interestingly, he had actually a Langerhans cell histiocytosis. So unfortunately, we don't have the slides, but I'll just talk you through the findings. They found that he had diffuse infiltrate of neoplastic cells. And importantly, what was significant was that there was moderate amount of pale eosinophilic to vacuolated cytoplasm, prominent nuclear grooves, and also cells with multinucleated forms. So also when they did immunohistochemistry, there was CD1A, S100, and CD163. So these are all markers that would point towards a Langerhans cell histiocytosis. All right, so when we got this result, he was referred on to hematology, and they gradually tapered him off dexamethasone. Somewhere along the way, he had a bit of recurrence of pain, but no diplopia. That was about 3 months off steroids, and so he was started on a very low dose, 2 mg OM. They did a full skeletal survey, and other than a bit of arachnoid granulations up in the skull, but it was otherwise unremarkable, and this was deemed to be an isolated solitary lesion at the left cavernous sinus. The PET-CT showed that besides that left orbital apex focus, there was no other systemic disease. So because it was mainly a localized disease, initially they were planning for whether he needed adjuvant chemo along with this. But because it was a mainly localized disease, they discussed this with radiation oncology, and he was decided for radiation therapy. So he underwent 15 fractions of 30 grays altogether of radiation therapy to the left cavernous sinus. And 6 months after onset, no more diplopia at his latest review. Ocular motility is full, optic nerve functions were intact, and his visual fields have improved. And we also repeated an MRI of the orbits, and it showed that there was resolution of that cabinet sinus orbital apex lesion. That area along the left sphenoidal sinus, that little soft tissue thickening, was decided to be possibly some mucosal enhancement. So this is a summary of the case. This is a 33-year-old gentleman with a left orbital apex syndrome secondary to Langerhans cell histiocytosis. What was involved was the left optic nerve, a partial third nerve palsy, as well as the sixth nerve, and it all resolved after a course of dexamethasone and radiotherapy. All right, just a little bit on Langerhans cell histiocytosis. So this is a very, very, very rare tumor. It's most common in children between 1 to 10 years. Sorry, what? Okay, sorry. Okay, I'll just continue. It's about 2 to 5 in 1 million children, and it's proposed to be a transient immune dysfunction, triggering proliferation of pathologic Langerhans cells, affecting the bones with bone marrow. Yeah. So these can be either solitary lesions or multifocal. Solitary lesions are usually treated intralesionally. So you can do surgical curettage, especially when you're doing the biopsy, you can just take a little bit more. Secondly, you can do intralesional steroid injections or low-dose radiation therapy. Multifocal diseases, which is systemic, would require systemic treatment with steroids, with or without chemotherapeutic agents. And of note, the solitary lesions with prominent retroorbital or intracranial soft tissue extension should be regarded as CNS risk lesions, and they do require systemic therapy under the international treatment protocol. So, which is why our patient was considered for systemic chemotherapy at one point. But because of his really good response to dexamethasone and how it's just a solitary lesion, after the tumor board discussion, they decided that he would just benefit from purely radiation therapy. So that's the end of my first case. Could I check if there are any questions?
Okay, you want to continue with the second case?
Second case,
first?
okay.
Yeah, and then.
Okay, let's
Thank you.
move on to the second case. Okay. All right, so this is a 68-year-old lady with ischemic risk factors, diabetes, hypertension, hyperlipidemia. She had previous ovarian cancer, but that was treated with surgical excision as well as adjuvant chemotherapy, and she was in remission. Her ocular history, however, was very extensive. Besides left cataract surgery, she had right retinal detachment, had phaco, had cataract surgery as well. She was left aphakic, but otherwise she had no diabetic retinopathy. So for her, what happened was she presented with 3 to 4 days of binocular vertical diplopia, sudden onset, but she felt that it seemed to be worsening over these 3 to 4 days. She was not the best historian, but she didn't really describe it as fatigable. There was no diurnal variation. She didn't have the generalized myasthenia gravis kind of symptoms, and otherwise no proptosis, no ptosis. So these are the examination findings. She was 6'9" in both eyes. And besides being aphakic and having a myopic fundus, the ocular examination was pretty normal. However, she did have anisocoria, which was recorded to be equal in light and dark. She had no RAPD, and this is confirmed on reverse. Optic nerve functions were otherwise intact. She had this corneal sensation, which was reduced over the right eye. But once again, she was not the most consistent. Now, on examination, she had a bit of superior sclerosis over here. And she had lid retraction on down gaze. Sorry, we don't have a picture of it retracting on down gaze. But if you can tell, there's a bit of left eye adduction deficit compared to the right. And very subtly, there's a little bit of left depression deficit as well. So these are the orthoptic findings. She's got a left over right, left hypertropia that was worse on left gaze and similar on left and right tilt. And she had a bit of an exotropia that was worse on right gaze as well. So our current diagnosis, our working diagnosis was the possible left partial third nerve palsy with possible aberrant regeneration because of the lid retraction on down gaze. The other differentials were ocular myasthenia or thyroid eye disease because of that lid retraction as well. So she was arranged for an urgent CT angiogram to rule out a posterior communicating artery aneurysm. Okay, so this is the CT angiogram. It actually found that she had a focal fusiform aneurysm at the basilar tip. So follow the blue arrow. Yeah. And over here on the second picture, also a focal aneurysm at the basilar tip also. And if you follow the orange on the third picture, the orange arrow is actually pointing to a near complete opacification of the left sphenoid sinus. Yeah. So she was reviewed by neurosurgery urgently, and their impression was that actually the third nerve palsy was unlikely to be related to the focal aneurysm at the basilar tip. So she underwent MRI brain, and the MRI brain actually revealed this asymmetric soft tissue thickening and enhancement at the left orbital apex, the left superior orbital fissure, and the anterior aspect of the left cavernous sinus, and it seemed to be encasing the left intraorbital and intracanalicular segments of the optic nerve. The sphenoid sinus wall appeared to be sclerotic and thickened, and there were some suspicions of the sinus itself having possibly some fungal elements. This is a possible finding. Okay. So because of the sphenoid sinus findings, she was teed up for a CT sinus, which confirmed again chronic left sphenoid sinusitis, but not much dehiscence of no overt dehiscence of the walls of the left sphenoid. So right now, our working diagnosis was a left partial third nerve palsy with aberrant regeneration, possibly secondary to a left sphenoid sinusitis. The ENT team came on, and she was listed for FES the next day. Okay. So she underwent the left FES, and intraoperatively, they found that she had edematous mucosa at the left sphenoid sinus, and there was also pus. So she was referred to infectious diseases. They started her on IV cefepime, 2 grams, 8 hourly, but held off the antifungals for now. So after 2 days, she had left V1 and V2 reduced sensation. However, the motility actually improved, and she mainly had a left adduction deficit left. So she was kept on the IV cefepime, and eventually the intraoperative cultures returned. And besides, and everything mainly was just skin flora, but her left nasal cavity actually grew Staph aureus with some mixed bacterial growth, and fungal smears and cultures were negative. And besides some reactive lymphoid tissue, there actually wasn't any malignant tumor that was found on histopathology. So the intravenous antibiotics were switched according to sensitivities, and she underwent a PICC line to complete 6 weeks of IV cafazolin. Now, these are some other investigations that we did, and the thyroid workup was negative. The myasthenia workup was negative. We even did neostigmine test, and the lumbar puncture was otherwise normal with no malignant cells, no lymphoma found. So these are the follow-up orthoptics for this patient. So a week after the FES, she was already improving. You can see that the left hypertropia was improving, and the left XT on right gaze was also a lot improved, like 20 to 8. And then a month after the FES was done, she only had a bit of esophoria left. And then 2 months after the FES, and this is after she's completed 6 weeks of IV antibiotics, she's completely well again and no more diplopia. So this is another interesting case of left orbital apex syndrome from Staph aureus sinusitis with no orbital cellulitis, with left possibly pupil involving CN3 palsy, corneal sensation reduction, with V1 and V2 being affected also, which resolved after a left FES and 6 weeks of IV antibiotics. So this is just a quick slide on infective orbital apex syndrome. Most of the time, it is associated with invasive fungal sinusitis. Or if it's bacterial, it will usually track from an orbital cellulitis into the orbital apex and then the caved sinus. And very rarely does it happen as just an isolated bacterial orbital apex syndrome without orbital cellulitis. And so far, there are only about 8 case reports in literature, maybe 9 now. So the treatment would be intravenous antibiotics, early endoscopic decompression of the orbital apex if the optic nerve is involved. And also we can consider corticosteroids to reduce inflammation after these two interventions are done. Yeah, so that's it from me. Yeah, maybe you can invite some questions.
Okay,
There's a question from Kota Baru. So Shida, is your question referring to the first case or the second?
I think the first case, yeah, Prof.
The first case, yeah.
I'm referring to the Langerhans sound histiocytosis now.
Okay.
Yeah.
I think the problem is when you first. Jaslyn, you want to answer that question, or should I take it?
Okay, I can try.
Okay.
I think the problem with the caved sinus biopsies are that firstly they are a bit invasive. So our ENT and our neurosurgery colleagues, I think they tend to hold back a little bit if we can find our etiology from another source. So if the lumbar puncture can pick up malignant cells or it can pick up lymphoma, then maybe we can spare the patient a biopsy. I think that's usually the case. Yeah.
That's what we would do. Just I think getting a lumbar puncture often is the simple first step when you have all this, because the biopsy does actually take a little bit of time if you think for histology. So sometimes you find your answer earlier. Although I must say that doing lumbar punctures for all these orbital apex syndromes has been singularly disappointing because we come back with very low yield most of the time. But yet we somehow seem to be unable to give up on doing it. Logan, your question is, yeah, I mean, the tip of the basilar fusiform aneurysm, sometimes this one is small, so I think probably it will just be observed for the time being. No real action to be taken on that as well. So thanks for the question.
Prof. Clement,
yes.
I saw that for the two cases, you always examine the thyroid and the myasthenia. Is it a routine, or is there something in these two cases that we have to worry that this one case is connected to the thyroid or the myasthenia?
I'm going to ask Jaslyn to answer that question because, yeah.
Okay. I think most of the time when the diplopia or the ophthalmoplegia would isolate very nicely to a single nerve, then we can skip out on the myasthenia and the thyroid function workup. But when it's kind of involving more than, doesn't really isolate nicely to a single nerve, then we would be thinking complex ophthalmoplegia. So myasthenia would be one of our differentials. And for the second case, with the patient having a bit of superior scleral show, a bit of lid retraction, possibly, could it be lid lag? Then we teed her up for a thyroid function workup. So, yeah.
So I think I tend to put it down to our residents here being very enthusiastic and on the ball. So when they see something they see a complex ophthalmoplegia, they decide that rather than wait for the consultants to tell them why didn't you take the blood, they just do it all first. Right, so that when they ask, they say, "Oh, I already sent off the blood." So then they come out as a very well organized residents. So I have no heart to tell them not to do it.
Okay.
Since clearly they're thinking, right? Since they're thinking, so I have no heart to tell them don't do it. Because usually when they see the patients at emergency or in the general clinic, right, they have no further information. There's no scan available. There's nothing available. They're simply acting on the fact, like in the first case, it's a young man with no known risk factors, and he has what looks like an isolated cranial neuropathy. And for a young man with an isolated cranial neuropathy, no known cause, the normal course of events is to get an MRI scan, maybe a lumbar puncture if the MRI scan turns out to be negative in case it is first presentation of a lymphoma, or to consider maybe this is a myasthenia, because it can present with any other any muscular weakness. So rather than wait for the scan first to be negative, then take the bloods, which will then take another 2 weeks to come. I know that sometimes we are a little bit enthusiastic and just investigate everything. Yes, I know where my taxes are going to right now.
Yes, maybe a little bit different for us because investigations is not every is covered by the insurance, so we need to have the SOP that which one that we need to take first the examination. So not all the examination we can do.
Yes. No, I completely understand that, and I don't necessarily suggest that. I don't think I would suggest in any way that all these should be a routine. For every patient who comes with a slightly odd-looking ophthalmoplegia. I think that for certain, if there's a complex-looking ophthalmoplegia, then your imaging is probably, if you have to bet on something, you do the imaging first, and if the imaging is normal, then you can proceed and do the rest. So taking a stepwise approach is also another way to do this, right? Yeah, good question. Why was there lid retraction? Jaslyn, why do we have lid retraction?
I purport that it could be part of the aberrant regeneration for the patient.
It's possible as part of the aberrant regeneration. Maybe if you go back to the photos of that patient and have a look, right? Sometimes the question is whether or not we've managed, when you see that lid retraction and then you look at the patient now looking at left gaze and right gaze, and there isn't that much of a lid retraction when the patient's looking left and right. And the question sometimes in my mind is, okay, did we actually fix the brow properly, and is this just reactive? The patient is just trying hard to open the eye because they don't see, they feel the lid is a little bit heavy. So I can't say for sure in this case why there's lid retraction, and I don't think it's directly necessarily related to the pathology itself per se, other than that this might be aberrant regeneration. That said, because when they examined the patient in down gaze, there was a little bit of lid retraction. I say, well, that's possible. It is possible, but no definite answer to this question, I'm afraid.
Thank you, Prof. Clement. Maybe Dr. Sidik, do you have any comments on these cases? Please, Dr. Sidik. No. Okay.
Dr. Sita, can I have a question? Yeah. That's the case. Perform the therapy case. Need to separate some involvement in this case.
I think there wasn't any, because they did a PET scan and they looked around for other involvement to see if there was other foci this Langerhans histiocytosis. So there not being any others, then it makes sense not to try to perhaps overtreat the patient. Although, as Jaslyn pointed out, the protocol in this case is to assume it is, but I defer to the oncology colleagues. If they say no need to treat, then I also will I will grit my teeth, and our job was therefore to then monitor this patient really, really closely thereafter, and make sure that there isn't a recurrence in that same area or something else that occurs any other part of the body. He will probably have to have some kind of follow-up later down the line. Yeah. Before we go any further, actually, I do want to acknowledge Katharina Gonadi. Kat is here somewhere. These are Katharina's patients. She was the principal person managing all these two patients. They very kindly provided them for this grand round. So, Kat, thanks very much for the patients, and yeah, she took care of these two patients very well during the entire time.
Please, Dr. Katrina, do you have any comments on these cases?
Actually, regarding the lid retraction, there was definitely, okay, I do not know what's the pathophysiology of the lid retraction, but on presentation, there was definitely a lid retraction on down gaze on the left side, and on follow-up, the lid retraction disappeared together along with the improvement in the motility. So I do not know the pathophysiology of it, but there definitely was related. I mean, the improvement was after the treatment. The motility improved together with the retraction as well. So I have a feeling it might be related to the third nerve, but I'm not very sure.
Thanks, Kat. I agree. It's probably that, but and we may never know the answer to it. It's a bit of a conundrum, whether that it's just third nerve alone, or whether it was something irritating the levator. I don't know whether we'll find a final answer to that. Yeah.
Yeah.
I think these two cases for me highlight one really important thing, and that is chasing down the pathology, and often in these orbital apex cases, it is really hard to decide how to treat them until you can get a bit more definitive pathology. It used to be that we would often consider those where the lumbar puncture was negative, and it was just enhancing on the MRI. We sometimes think, okay, maybe this, and the sinuses were relatively clear. We think, okay, maybe this is just a form of Tolosa Hunt, and then we try to treat them with steroids. But I think increasingly, I feel the need to get hold of tissue and to persuade somebody to get us some tissue. In this case, in these two cases, it was perhaps helpful that a lot of the lesion was on the sinus side of things, and so the ENT people can reach it easily. It's a lot harder when it's just the cavernous sinus alone that's involved, and the neurosurgeons are then a bit more reluctant to go in and grab hold of something, do a blind, not so much a blind, but do a biopsy in that region, because there's so many cranial nerves running there, and they might end up causing more damage than getting tissue. So those are the really hard ones.
Prof, I have one question. Are there any specific signs or symptoms that differentiate ophthalmoplegia caused by Langerhans from the other etiologies?
I don't think so.
Langerhans is very out of the box.
Yeah, I know. So
yeah.
so even Staph aureus, right, is rare, right? So who would have thought Staph aureus would cause this? But I don't think there are any clinical signs to it, and that's why I say the tissue biopsy is often really the key. The real challenge is not finding that there's a lesion there. The real challenge is persuading somebody to biopsy it and say, we need tissue, if not we can't treat this. And I will take these two cases and keep showing them to the neurosurgeons and ENT people to persuade them that we should get hold of tissue. As to Staph aureus, I think the one comment that I have about it is frequently we see it as a contaminant, right? And then we don't know if there is actually fungus behind it. So I also hold my breath a little bit about that in case there's one. But of course, the cultures were negative. But we also know, I also have had patients before where the culture has been negative twice or two times, and the biopsy is negative 2 times, and the third biopsy is finally positive. So fungus is often very tricky. The aspergillus especially is a bit tricky to diagnose and needs you need to be quite tenacious in trying to get hold of tissue, especially if the first few are negative, and if the patient doesn't respond to treatment. In this case, the patient responded to treatment. But what is important to note for Staph aureus in these areas is it really does require 6 weeks of IV therapy. You can't just send them off on Augmentin and hope that they'll get better. You'll need 6 weeks of IV therapy, if anything, in these regions, for the penetration as well as for the completeness of therapy.
Thank you very much, Prof. Clement. Are there any other questions from the audience? I think there's no question anymore. And thank you, Dr. Jaslyn, for the interesting and challenging case presentations that led us to think out of the box in exploring the cause of diplopia. And because of time, we must end our discussion. And some pearls that we have learned from this meeting are the filler injections can result in devastating ocular complications, include vision loss and diplopia. And the mechanisms include vascular occlusion or direct infiltration. And glabella and the nose are the most dangerous injection sites. The second one, Langerhans cell histiocytosis, is a rare disorder of the orbit and should be considered as a differential diagnosis for ophthalmoplegia with osteolytic lesions involving the orbit. And histopathology and immunohistochemistry are essential for the diagnosis. And the third one, bacterial sphenocytitis may cause partial cranial nerve palsy. Neoplastic process must be ruled out, and the early surgical intervention with intravenous antimicrobial therapy carry an excellent outcome with a complete resolution of symptoms. Thank you very much. And as we wrap up, I would like to thank everyone for your thoughtful contributions to today's discussion. Thank you, Dr. Lily and Dr. Jaslyn, for the interesting case presentations. Thank you, Dr. Salma and Dr. Katrina, for the patience. And thank you for Prof. Clement, Dr. Sidik, Dr. Synthia, and Dr. Salma. Your insights have been invaluable. Thank you very much.
Moderating this
Thank
session.
you once again.
Thank you very much from Asia.
Thank
Thanks.
Thank
yeah,
you.
thank you once
Thank you,
again for
Dr.
joining us
Prof.
today.
Hi,
See
Sida.
you on the next
Thank you, everybody.
session.
Thank you
Okay,
for a good.
thank you,
Yeah, thank you,
everybody.
Prof. Clement.
Bye-bye.
Bye.
Thank you,
Bye.
everybody.
Thank you.
Thank you.
See you again.
Thank you.
Bye.
Bye-bye. See you.
Assalamualaikum.
Waalaikumsalam.
Recording stopped.